Welcome to the Physician Associate Podcast.
Hello and welcome to this episode of the Physician Associate Podcast. My name is James. Today I'm delighted to be joined by two guests to have a discussion about physician associates working in geriatric medicine. Welcome to the show, Dr. Rebecca Whiting and PA Paris. Dr. Whiting, do you want to introduce yourself first?
Yeah, hi, my name's Dr. Rebecca Whiting. I'm a consultant in geriatric medicine and frailty.
I'm Paris Walker. I'm one of the physician associates in geriatric medicine. Perfect.
Thank you very much. Did you choose geriatrics or did geriatrics choose you for a particular reason?
A bit of both, really. So I didn't really like geriatrics as a student. I was just saying this the other day. And I think it's because as a student, you don't really appreciate all the communication skills that you wouldn't kind of be handed to do as a student. There's less kind of those skills that you can do when you're actually working there and can truly fully understand and appreciate the clinical decision making, the stuff that goes into it, the family discussions, understanding patients' concerns and things. That's when you really appreciate it. So it was when I had my first job there, once I'd qualified, and then a job on frailty, that really kind of sparked my interest. So I guess it grabbed me and then I grabbed it moving forwards. So yeah.
Perfect, thank you. Dr. Whiting, as a consultant in geriatric medicine, how do you use the physician associates that you have in your service?
They are the permanent members of staff on the ward. So they are the team that really hold our organisational values and our ward-based values in terms of how we look after our patients. They kind of hold that sort of moral culture within their team of how we look after our patients. And in terms of improving the service and developing the service, my experience of working with PAs in things like quality improvement is that they're the people that can enact and maintain lasting change on the ward, which is really wonderful. The other thing I've noticed, and I suspect Paris will talk about this, is that continuity means that quite often they get to know our patients. So in frailty and elderly care, we quite often see patients more than once. And it's really lovely and wonderful for when patients arrive, someone like Paris might turn to me and say, oh, I saw them 6 months ago and this is what they were like then. And they add that colour and texture and knowledge to looking after our patients in a way that's really hard to achieve in secondary care, actually. So from a consistency perspective, Paris and her group are really valuable.
Yeah, absolutely. And that makes things much easier for the patients as well as the clinical team and the patient's family and relatives as well, isn't it? If they see a friendly face who they've met before and who knows their relative really well, there's so much value added to that.
Yeah, and quite a lot of elderly care is nuanced decision making and building up conversations. So I was saying to Paris yesterday that I think her and quite a lot of her peers' superpowers is advanced communication skills. As a team, they have all got really, really, really good at challenging conversations, those tender conversations about end-of-life care, about resuscitation, about withdrawing or giving of certain treatments. And having the opportunity to build on those conversations over time, if there is continuity, is really, really important.
Absolutely. Well, that's wonderful to hear. Paris, what does a typical sort of week look like for you as a physician associate working in geriatric medicine?
Yeah, so at the moment I'm working on a general geriatric ward. It has been Monday to Friday with Tuesdays because I have a special interest in geriatric input in surgical geriatric patients. I've been spending my Tuesdays doing that. So the other days I will go to the ward and do a ward round either with a consultant or on my own, depending on kind of what that day looks like in terms of the team, and whether there's registrar support or consultant support. And then spend the afternoon completing the jobs from the ward round and having family discussions, patient discussions. We also get a lot of students that come through, both physician associates and medical students. So we also do some bedside teaching or just teaching as we go along with those students. So yeah, and then Tuesdays are a little bit different. So I usually go and see the consultant in the morning, discuss what patients need seeing, and then kind of give really thorough geriatric reviews for surgical patients when they request them. Go through some areas of their background and what they've come in with, what might help them in caring for the patients.
Having trained as a PA student and then landing on the ward, what skills had you found that PA school had really prepared you well for? And was there anything that perhaps you needed specifically to work in geriatric medicine to develop in your first few months and years?
Yeah, so I think clinical skills, we did focus a lot on at Leeds University. And when I was a student, I was always keen to go and do those jobs because I found that they were the most readily available jobs on wards that could be completed, particularly by students who like cannulas and bloods and things. Definitely communication skills is something that you have to work on once you're qualified, because I guess as students you don't really get those opportunities. I did shadow consultants or the seniors when they had those discussions, because I guess one thing that was drilled into me was that if you observe those discussions from lots of different people, you can pick up on your own ideas of where those discussions went well, what you might have said differently, and kind of formulate your own discussion plan. We were also talking about how those discussions don't always maybe go the way you expect them to, and dealing with those situations as they arise. And I think that's definitely what I've worked on and got better at as I've been working, which is really important in geriatric medicine.
And Dr. Whiting, is there anything you've noticed with physician associates that perhaps they need?
Well, I mean, I wouldn't want to speak to their experience, but I suspect one of the issues that is general to most healthcare professionals when they walk into elderly care is that elderly care can be more nuanced than other specialties. So the guidelines aren't necessarily generalizable to our patients. The RCTs were not done with cohorts that represent our patients. So one of the, I think, exciting but recognized can be challenging parts of elderly care is adapting that to our individual patients. And also recognizing what to do, but also recognizing what not to do and when not to follow the guideline, and that sort of individualized patient care, which takes us all years and time to perfect, whatever our origin story or background or healthcare professional background. So I suspect that's something that is a key transition point from popping out of a university and into elderly care. The guideline may say you find this, you do A, B, and C, but the patient may not want A, B, and C. They may not want a diagnosis. They may not be fit for treatment if you made that diagnosis, and taking into account all those wishes.
Can I ask you, in terms of as a consultant, as a supervisor for physician associates, how's that worked for you? What have you had to put in place in order to make sure that the PAs are supervised correctly? And if other geriatric consultants are listening to this thinking about employing a PA, what would you warn them about or tell them about is required?
Definitely employ PAs. PAs will be really valuable, and you won't realise how valuable they are till they are stood in front of you on your ward round. I think that the thing to be mindful, or the thing that I've found with how I work with the PAs on the ward, is that they're really useful and they are therefore in high demand for service provision and rotas. And consequently, you have to be really careful in actively protecting patient personal development and other interests for them. So I suspect Paris will agree, but I think it's really because of that general broad skill set, it can be really easy for them to be sucked into rotas and moved around as NHS pressures increase, particularly in winter and obviously with the recent pandemic. So I think one of the key things is sort of ring fencing and protecting from those pressures. The other thing that we're seeing in our trust is elderly is a specialty with increasing subspecialty options. We have elderly care teams providing care in orthogeriatrics, in perioperative medicine, in the community, in frailty, in same-day emergency services, in Parkinson's disease. So there is quite a lot of scope for individual PAs to consider areas of interest that they may want to expand upon or potentially specialise in. Now, there's no pre-mapped path for this. So it does, I think the areas where it's worked well for us have been where there has been a one-to-one relationship between a PA and a lead consultant, and it's required quite strong consultant leadership and organisational drive, because there isn't that, pre-mapped path that other healthcare professionals may follow to do that. So I think elderly can be quite good for that. And I think in terms of service need, depending on obviously what the PA is interested in, there are some really useful options there.
Leads me nicely on to another question I wanted to ask. Paris, how have you developed yourself as a PA in geriatric medicine? And do you have plans of doing qualifications and courses and that kind of thing? I
feel like I've developed massively. It's something you don't actually realise until you reflect on it. And I think most people would agree with that. You just kind of go to work every day, but you don't realise you're progressing, but you are. I definitely think, as we've already mentioned, those communication skills massively, and even those clinical skills, because some of the geriatric patients on the ward are really difficult to complete those skills for. They don't quite understand what's going on. Things are in their best interests. They sometimes have very small, frail veins, and you want to minimise that intervention as much as possible. So I think I do find having that good skill, I would say, in kind of cannulas and bloods when it's difficult. If I know I can go and have quite a good chance of getting it and minimising their distress for those interventions, it's definitely helpful. And then there's the role that I play in the geriatric POP service that we have at the Trust. So that's largely in also geriatrics, but there is also general surgical in reach that we do. And it's most definitely something that I'm really interested in. And I do like the ward as well. So it's nice to have that balance between the two, which the Trust offers. And I've seen the POPs course that the British Geriatric Society do. So that's something I'm going to look to do after Christmas. And I've also been looking at PhDs as well, because I'd like to kind of take that knowledge forward. I definitely think there's more there that I can do. But I do still like sticking with the ward stuff.
Absolutely. How well received or supportive of the British Geriatric Society and other sort of frailty medicine organisations been in terms of physician associates? Is it, I think you said, Dr. Whiting, there's not really any predefined career path at the moment. Do you think things are going to go that way? Is there support out there?
I think there's growing support. I also think it would be a big mistake not to. The Acute Frailty Network and the British Geriatric Society have both at many points discussed the fact that with the ageing population and the increasing rise of frailty and elderly care services, that there aren't enough geriatricians via the traditional training route to manage those needs. So we are already being thoughtful and mindful of what extra workforce we can employ to meet our service needs. And I think PAs would be a really pivotal pocket of that.
When you first started your job as a PA in frailty medicine, were there any resources or anything that you found really particularly useful that you would share for other people going into a similar role?
So not at the time, but I have been enlightened and given the registrar curriculum for what they have to know and learn. Obviously, it's not all applicable to physician associates, and probably more useful for physician associates looking at a career in geriatric medicine. That's certainly one that is now proven useful. The Geriatric Society have a few good articles and resources and learning tools that I would definitely recommend and did use at the time. There was nothing specific that I always went to, but now that curriculum that has been adapted by one of the consultants, taking out all those areas that aren't kind of useful or applicable to physician associates, that's definitely something that I'm working from now.
What do you see the future being for physician associates in your service, Dr. Whiting? Are there plans for skills expansion, clinics, service development that way?
I think that's a big question. And I think that's a question that's currently being answered between the PAs and their individual supervisors. I think there is certainly thought of looking at about how much more value PAs can add to our service in terms of things like the specialty in reach services and the specialty clinics. I know a couple of our PAs, Paris already does the POPs in reach, and we have a PA doing PD in reach and is now participating more actively in the PD clinics. So it's looking at how we can continue to build that, really.
POCUS, which is point of care ultrasound testing, because ultrasound testing can be quite useful. And one of the elderly consultants did mention it to me this week, as did one of the acute med consultants, and how useful it actually is at the bedside in situations where you can't get those tests so readily, but would be useful for patient management. And even patients who get quite distressed when they're taken down to departments and off the ward. So that was something that was raised recently, possibly being quite useful.
So recently somebody was sort of talking about careers advice they would give people on choosing a specialty. And they sort of phrased it as, if you can find out what you see the most common presentations on that specialty, and if you can find out what the real heart sync presentations are, and if it turns out you don't mind those things, that's probably a good specialty to choose. I don't quite know how to ask that as a polite question of, what do you see commonly and what are the heart syncs in geriatrics?
So most commonly, I think one of the beauties about geriatrics, which people definitely overlook, is, and I do still hear it said quite often, is that it's mostly social and it's mostly falls, which is definitely incorrect. It's, it's one of those preserved general medical specialties. We see everything: cardiology, neurology, renal, gastro, everything. And even if you don't see it on presentation, it could be because it's missed. It could be the cause of their presentation. So actually it takes digging a little deeper and, truly get into things, which is what you have to do in geriatric medicine to really get to the bottom of what brought a patient into hospital. So social things, yes, and falls, yes, are probably two of the most common things, and dehydration. But actually it's what's caused that. And sometimes that's overlooked as a presenting complaint.
I would agree with quite a lot of that, Paris. One of the things I love about geriatric medicine is that it really is general medicine's last stand. I think it's one of the last remaining specialties where we do look after everything. And we often stand at the interface of a patient who's known to 6 or 7 different specialties and have to manage their competing interests. The question about heart sync presentations, my heart sync on the bottom of a Clarking is query chest, query urine, followed by acopia. And I think I think that just demonstrates a lack of depth of understanding of elderly medicine. And actually, if you dig into those, it's never really acopia. It's someone who's no longer able to look after themselves because they are profoundly and critically unwell. And actually, you can flip that heart sync onto its head to being one of the biggest and most exciting challenges, which is being the investigator of trying to work out what's wrong with a person who can't always tell you.
Definitely, it's all about being like Sherlock.
There's a lot of similarities. This probably won't make the podcast episode, but there are a lot of similarities between paediatrics and geriatrics, aren't there, in terms of your patients present very differently to middle-aged adult population and have different types of diseases and different patterns that you only see at either extreme of life.
Absolutely. So sometimes our patients can't tell us what's wrong in the same way that children do. So, if a patient has delirium or dysphasia or advanced dementia, it can become more about clinical signs and clinical assessment, but also actually your biology at extremes of life, how you metabolize drugs, how your body works at a cellular level is different to that in middle age. So a lot of presentations are completely different in the elderly. And that's part of the skill of elderly care is understanding that.
From a practical point of view, working as a physician associate in geriatrics, often some of the barriers that are put up against PAs is our lack of statutory regulation at the moment, although the GMC are going to regulate us hopefully in 2023. and the lack of prescribing rights for physician associates. But working practically, Paris, how much of a barrier or a problem is that for you?
Yes, I think, again, this is where geriatrics is actually really positive, because quite often it's about deprescribing for these patients and identifying medications that they potentially don't particularly need or might be causing them more harm than good. So that's really useful. Obviously, there is always prescribing, like in any other job. But when I compare that to the rotations that I had through other specialties, such as respiratory and cardiology, and some areas of acute medicine, that's very prescribing heavy. And yeah, so that's one of the better things about geriatrics, is that there's not really, you don't notice those limitations as much. And we just deal with that at our trust anyway. There's always someone there to prescribe for us. So yeah, it's good.
Would you agree, Dr. Whiting, with that not being in practical terms much of a barrier to employing PAs?
I would. I think it's a really sort of small-minded view that we can't find someone to support in a prescription. I'm usually stood next to Paris when I ask for a prescription. There's no reason I can't prescribe my own patients' medications. I also think that if and or when prescribing comes, the PAs that have worked within frailty and elderly will be really well placed to embark upon that journey, because we have lots of in-depth conversations about medications. Every prescription we make and every prescription we stop is really well thought out, and we often talk about it because with the evidence base isn't always there. So I think they'll be really well placed if and when that does come.
Absolutely, yeah, it's really good training for your pharmacodynamics and pharmacokinetics.
One of the reasons that I hope that PAs have integrated quite well into elderly care is that we are a specialty that has been multidisciplinary from the outset. We are a specialty that prides ourselves in acknowledging the skills that every member of the MDT brings. And as a result, we work with quite a lot of different healthcare professionals on a day-by-day basis. And I really hope that that's helped PAs integrate within our teams.
Yeah, that culture is very different, I suppose, to some other specialties who might not have had anybody other than a doctor.
Absolutely. And within the trust, we have quite a large advanced care practitioner body, and within elderly, we have quite a lot of trainee ACPs as well. So we are quite mindful and aware of, I suppose, what used to be non-traditional roles, but increasingly aren't, which I think helps.
Certainly, yeah, it helps integration and acceptance of the role, doesn't it?
Yeah, I would completely agree with that. I think actually just reflecting now, it's probably one of the areas of medicine where, you didn't kind of get more these funny looks about just as to your role. It was just kind of another role of part of the MDT. Whereas like we've already touched on, so many specialties, it's just a doctor and a nurse part of it. So, yeah.
I wonder as well, Paris, we talked about people trying to make parallels of like where you fit in the hierarchies. Like, are you like an F1 or are you like an SHO? Neither of which is fair, because you are, of course, your own distinct species. But I wonder if, because we have so many distinct separate roles within the MDT, it's to say, well, no, I'm a PA, that is my role here, in the same way that our ACPs do and our therapists do.
Yeah, much easier for someone else to understand you're part of the team, rather than having to fit into a box of what's come before you. Thanks so much for talking to me on the podcast today, guys. I found it really interesting myself to find out more about geriatrics as a specialty, and you've convinced me that I might want to consider it in the future. If anybody else has been listening to this podcast, student PAs, qualified PAs, perhaps other doctors and consultants, service managers, it may have sparked off some questions in their head. Where would you point them to go to find out more information?
So in terms of geriatrics as a whole, there's some really good resources on the British Geriatric Society website. Also, the Acute Frailty Network is a really good spot. And obviously, if there's anything you want to contact myself or Paris about, I'm more than happy for my email to be in the show notes, and you can get in touch that way.
And similar for me too. My email can be in the show notes as well. And you can also contact me, and my Twitter is @ParisSorrell.
Perfect, thank you. I'll leave your details in the show notes so people can find them there. And I hope you found that really interesting to listen to as well, to find out a bit more about geriatric medicine and physician associates and how they work in that specialty. If you've got any ideas for future episodes of the Physician Associate podcast, I'd be delighted to hear from you. You can get in touch with me. I'm on social media, Facebook, Twitter and Instagram at PA Podcast UK. And I hope you'll join me again for the next episode.
Thanks for listening to the Physician Associate podcast.